Hello, I am Dr. Beck, and I'm going to present today on the prevention of urinary tract infections, antibiotics, urinary tract infections, bathing, and disinfection. I received my Bachelor's of Microbiology from the University of Rochester, my Master's, again, in Microbiology from Washington University, St. Louis, and my PhD in Microbiology from the University of Virginia. I now work at Tennessee Technological University as a microbiologist. If you wish to contact me, my contact information is provided. First, a conflict of interest statement. I have received no financial support or benefit of any kind for the research done here or in this presentation. However, the research here was supported by a diversity fellowship from Tennessee Technological University to Kimberly Hart. She's my graduate student who's been assisting me with this project and has been doing the data analysis that I will discuss later today. The first thing I would like to talk about is the prevention of urinary tract infections, particularly why prevention is essential for the management of urinary tract infections, or frankly for any infection. Later, I will discuss defining of UTIs in the elderly, and then in the second part of the talk, I will discuss bathing of the mobile elderly patient and disinfection of the shower chair. So first, why is prevention essential for the management of urinary tract infections? We need to understand, and this is critical, that we have entered the post-antibiotic era. We have this idea that we are going to go to the doctor and get antibiotics. Sadly, this is becoming less true every day. We hear about it in the news: MRSA, VRE, carbapenem-resistant E. coli, etc., etc., etc. It is very severe and getting worse every day. The bottom line is prevention is far cheaper than any treatment. So if we can prevent disease, we do not need to worry about treatment. And obviously, quality of life, I'm not going to discuss that due to time. Obviously, if a patient is healthy, they have a higher quality of life, higher survival rates, and that is also, financially speaking, very good for your nursing home to have better indicators on nursing home comparisons and for funding purposes. Now, the first thing I'd like to discuss, I know this slide is a little busy, so let's start up here in the top corner here. And the first thing you can note when we're looking at this is sulfonamides were introduced in the late or the early 1930s. Penicillin was introduced to the public around 1943, 1944, and it was a number of years before we saw drug resistance. If we just watch the sulfonamide line, we introduced the sulfonamides in the 30s, and we saw drug resistance to the sulfonamides later in 1946-47 approximately. You'll notice each time we introduced a new antibiotic, there was a 3 to 4 to 5 year gap before we saw antibiotic resistance. This first changed with neomycin, and as we've moved forward, we have large gaps most of the time. However, since 1980, every new antibiotic introduced, we see resistance in less than 24 months. And you can see that in the bottom half of this graph. Every new antibiotic introduced, less than 24 months later, the resistance is observed. If we move to the other corner of the graph, we can see here's another graph. We're just picking on one hospital here. You can change the name of the hospital to whatever you want, and the data will be similar, although the numbers, exact numbers, will be slightly different. But here, if you look at St. Joseph's Hospital, and we look at the emergence of antibiotic resistance bacteria in the surgical ICU, what we see is an overall trend from 2004 to 2010 that we went from less than 5% of the isolates being antibiotic resistant, these are multi-drug resistant strains, to more than 10% of the bacteria being antibiotic resistant. And you can imagine we're now almost 6 years out from this graph. It's getting worse. If we look at these antibiotic resistance, we see carbapenem extended spectrum beta-lactamase resistant Klebsiella and E. coli and MRSA, all increasing in the ICU. Resistance is emerging at an alarming rate, and this is true for many, many bacteria. I can show you graph after graph showing this same result. For the sake of time, though, we'll just leave it with this one. Okay? Now, if we look to the last corner, the bottom corner here, what we can see is this is new antibiotic drug applications submitted to the FDA. So this is companies preparing an antibiotic, even a modification of an antibiotic, and trying to get licensing to sell it to the public as a prescription drug. Okay? There's less and less and less and less and less and less. Every 5 years we reduce the number of applications for new antibiotics. We don't have a lot of antibiotics in the pipeline to replace these antibiotics that the bacteria are becoming resistant to. We are frankly running out of antibiotics, and we are frankly running out of good ideas. So let's look at antibiotic resistance over the last 60 years. So miracle drugs. We have miracle drugs back in 1950. We had all kinds of antibiotics that came onto the market: streptomycin, penicillin, sulfonamides, neomycin, bacitracin, chloramphenicol, tetracycline, kanamycin. We got a bunch. We were able to kill the bacteria quite efficiently, and we started seeing drug resistance emerging in 1948 and 1947 to penicillin and sulfonamides. All the drugs that have fallen at his feet are where drug-resistant bacteria have emerged to that antibiotic. So let's look at 1960. We got a lot more antibiotics falling down here at his feet. We still got a lot of antibiotics in his backpack. He's still going in 1970, Our drug resistance is increasing. We're now seeing multi-drug resistant bacteria with multiple drug resistances. 1990. His backpack's starting to look a little empty, and he's starting to look a little worried here, okay? We have run through a lot of antibiotics and a lot of varieties of these antibiotics. And we're seeing VRE, MDR Pseudomonas, MDR TB, MRSA, and we are starting to build a tidal wave of antibiotic resistance. In 2010, we've got a few more antibiotics, but we've run through a lot more cartridges of different kinds of antibiotics, and our ability to treat infections has significantly decreased. We can kill a lot of things still, but there's a lot of things back here that are multi-drug resistant, which means 1, 2, 3, maybe 4 antibiotics still work. That means we are in serious trouble. And we are in the post-antibiotic era. It won't be long, and the cartridge will be empty. And for some of these bacteria, it is already empty. You'll notice on here, for instance, totally drug-resistant TB. The CDC and the World Health Organization do not like this definition. It is resistant to 12 out of 12 known antibiotics for treating TB. You can call it whatever you want. 0 drugs remain in the formulary for treating tuberculosis anywhere in the world for this particular variety of tuberculosis that is now in 4 countries and spreading. And so this avalanche and this tidal wave of antibiotic resistance is coming at us, and if we do not prevent disease, when these bacteria come into our nursing homes, they are going to devastate us, devastate our patients, and devastate our bottom line.